Hello, good afternoon everybody, and thank you very much for coming to join us for one of our 108 Harley Street CPD Snippets series. This is one of our webinar series where we try and highlight some common topics that are relevant to the different specialties, and today I'm going to be talking about frozen shoulders. The format, if you've not seen one of our snippets before, is going to be as follows. We have one topic, we try and cover this with, we have one or two key slides. Takes about 20 minutes. If there are any things that you'd like us to talk about, you have any recommendations for any future topics that you'd like us to cover, get in touch with us on the email address that you can see below. And also, if you have any questions for us, please do feedback to us and we'll try and get back to you if we can't during the course of the webinar itself. So what is a frozen shoulder? So contrary to popular belief, this has got nothing to do with the temperature. This is actually a condition that's medically. What happens? This can become those of you who will have seen these pictures before will know the shoulder is a very complicated joint which has a lot of different anatomy. But essentially, the areas that are in between our tendons, which is the shoulder capsule, can become very thickened and inflamed. This can happen for a number of different reasons. It can happen because of trauma, or it can happen because of an idiopathic or not any obvious reason that we can explain. And it classically goes through three phases. We tend to go through what's called a freezing phase. Now, this is where patients will generally complain of being a lot of pain, a lot of discomfort. It's very, very sore. And it's actually quite important that you don't try and push patients to move too much through the freezing phase. So we know that actually makes it. So do be careful if people come in with that history for you. Once it's actually gone through the freezing phase and restricted, the shoulder's then actually frozen, which doesn't actually tend to be quite as painful. So the pain improves, but the range of motion is significantly less. And patients will generally come to you saying that actually, my shoulder's not as bad as it was, doc. I still have problems with sleeping at night, for example, but actually my range of movement is a problem. I'd really like to get this better. And then the final phase is the thawing phase. Now what happens there is that the shoulder will gradually start to loosen up a little bit, and it can take up to 18 months or sometimes longer for patients with pre-existing conditions, but in particular diabetes, to get better, but it will normally improve significantly. It doesn't always tend to come back to how it was before the frozen shoulder though. So I do counsel you to tell your patients that you may not get the full range of motion back that you had before, but unless you're actually measuring angles, for example, to go in your in the history of a frozen shoulder, because no one actually comes to you and says, I've got a frozen shoulder, doc, unless of course they're medical. So quite often patients will have had a frozen shoulder developing for a little while, but they may not have noticed it. And one of the things that I find comes to my clinics quite a lot is that patients will tell me, I was reaching across my chest, doc, to grab a seatbelt, this kind of a movement, and all of a sudden I had the pain and it came on then. And so a lot of patients actually will think that, for example, I'm looking in the back of my car, I'm reaching behind me to get something from the back seat. Pain was there before and the shoulder was starting to freeze, but they hadn't put themselves through the movement to notice it. So look out for that when you take the history from your patients. Obviously, patients who've had a traumatic history of an injury will be more easy to pick up. So what will you find if you examine a patient with a frozen shoulder? So you'll have a restricted range of motion of the shoulder joint, and this will be restricted in all directions, which is a very important thing to look for. And significantly, it's also reduced in both the passive and active range of motion. The reason that's relevant is that a lot of patients, for example, with cuff pathology may have a full movement, but their active movement will be reduced, whereas with a frozen shoulder, both sets of movements are impaired. The way I explain it to patients, if you imagine my jacket, it's normally loose and you can move it all around, but a frozen shoulder is like a jacket and holding it very tightly so you can't move in all the different directions. And that's how I explain it to patients, which sometimes is helpful to explain to them what's actually going on with their shoulders. How do you diagnose it? Well, we used to say that frozen shoulder was a purely clinical diagnosis, and by and large that is true. However, you do need to have ones we have to look out for, which can give a reduced range of motion, would include obviously osteoarthritis, which will show on an X-ray. If someone had a history of trauma, they had a locked dislocation, that would show on an X-ray. that the patient would have reported that to you before they came to see you in a clinic. And significantly then, of course, the frozen shoulder itself. We always get 1 or 2 cases a year, predominantly in our older patients, who actually have an unrelated problem in their shoulder, which is thought shoulder, but occasionally it can be a location for presentation of a secondary malignancy. And we know, for example, in the over 40 age group that a metastatic disease in the bone is very common around the shoulder. So if someone is in that age group and has had shoulder pain with no other obvious precipitant, I would strongly recommend you get a plain radiograph if the symptoms are persisting beyond 6 to 12 weeks to make sure you're not missing something more significant. But as I say, in a frozen shoulder, you would not expect to see anything abnormal on an X-ray. How would you then look at it inside a keyhole operation? This is an arthroscopic appearance of what a frozen shoulder looks like. On the left of the screen, you can see the humeral head. On the right of the screen, you can see the very red and angry, almost like a sea anemone appearance of an inflamed capsule. This is one I did yesterday actually, and this patient has had problems for more than a year. So although the natural history that we're taught about frozen shoulders is that they will get better within a year, clearly that's not the case for everyone because they do persist. And this is obviously very difficult to sort out once it's gotten as bad as this. Treatment options that are available to us, well, the classic treatment is obviously physiotherapy with a steroid injection. That was done into the glenohumeral joint. I personally recommend if you're going to do that, you do that under guidance where possible so that you know you're in the correct place. But also in the current COVID pandemic, we do need to be aware of the fact that there is a risk of potentially reducing people's immunity to the virus, and also that the people that live in their support bubble at home should be shielding for 3 to 4 days. So I'm not so keen on steroid injections at the present time. Other options then, of course, are surgical solutions which require anaesthetic procedures. And this is something that is obviously difficult to get hold of now because of our access to theatres has become significantly reduced with the COVID pandemic. Quite rightly so, our patients who have urgent surgery, for example, patients requiring cancer treatment, take priority, but it does make access to theatre quite difficult. So this situation has left us with a question, well, what do we do with our patients with frozen shoulders who perhaps may have been immobile due to being in lockdown, the gyms are closed, they can't get out and have treatment, but they want something doing and they're in pain. What can we do? We can't get them to theatre. We can't do much else for them. Is there another option? Well, there is. This is a relatively new technique, which I was going to tell you about in a moment. So just to summarise the key take-home points about frozen shoulders history is about the fact that most of them will improve. To get an X-ray and obviously exclude them. This is our key slide. I want to just come back to that because if you take nothing else away from this talk, the main thing I'd like you to take away is to be aware of those 3 main points. Just coming back to what I was alluding to, what can you do for these patients in the current situation? Well, one of the things that we're very proud of, innovation led from Jerry Gilmore, who sort of was such a world expert on the hernia treatment, and of course, Mr. Marsh, who's followed in his legacy. My small part that I've tried to bring to 108 is this device that you can see in the picture called a MyEye. This lady had a frozen shoulder, and it was after an injury, so she had a traumatic frozen shoulder. And this is just an office-based technique that we've put local anaesthetic in the shoulder before we put the fluid in, and then you can see that we're stretching out the shoulder joint to try and help her improve her range of motion. The next video that I have for you, I'm hoping you can see, and I'm hoping this will run for you, shows that on the left of the screen is what the range of motion that she had in her right shoulder was prior to the treatment, and on the right is the movement that she had in the shoulder immediately after the procedure in the clinic. That's not the end of it. Patients still have to have physiotherapy afterwards. They still have to engage with the process, but they can actually do very well. This lady's movement for forward elevation is significantly better. She still has some tightness. As you can see, she has that classic hitch in the scapula, but that was a lot better than the 90 degrees that she had when she first arrived. So there is another alternative that we can offer. I think you'll find that frozen shoulders are a very common condition. They'll become more so in the time that we've got around the pandemic. There are things that we can do to help, and be grateful to hear from you if you'd like us to see some of your patients. The details on the screens are the details of how to get in touch with us. And just a thing to let you know, our team is a multidisciplinary team. As you can see, there are a number of different specialties that we cater for in 108. And our next CPD snippet will be on the 27th of November. And our general surgeon and colorectal surgeon colleague, Mr. Emin Carpetti, will be doing a talk on pilonidal sinuses, which I hope will be helpful and useful for you. So that was a quick whistle-stop tour of frozen shoulders. I do hope that was of use, and if you have anything further you'd like to ask, please do get in touch. And I wish you all the best, and do stay safe in these challenging times. Many thanks. Bye for now.